Dr. Waggel, what's your hope for the next decade in mental health? Like, what do you hope that we can accomplish or see here in the next decade as people start to become more aware of mental health and we start to treat them better?
In the future, I hope that there are more programs that incorporate education about how to treat pregnant people. And that way I don't get these frantic texts from my colleagues like, hey,
Mhm.
I have this patient and now she's pregnant and I don't know what to do. And I'm like,
Oh,
oh my goodness. So in the future, hopefully I get less frantic messages like that. And, since we were talking about it, I think in the future, if it was more mainstream to be preventative when it comes to mental health, and you're right, it shouldn't just be waiting until your whole world implodes to get help. And like I said earlier, like you might not necessarily even have like that like big issues, but talking to somebody can help with all sorts of things. And so waiting until the world explodes, you're waiting too long.
welcome to NICU Heroes, a podcast produced exclusively for NICU professionals, with me, Kathryn Whitaker, as your host. I'm the mom of 6 children, including my very own NICU baby. This podcast is produced by Hand to Hold, a national nonprofit dedicated to providing free personalized support, resources, and community before, during, and after a baby's NICU stay. As a NICU professional, you've been well trained to care for the tiniest and the sickest babies every day. While a NICU parent's scars are not as visible, those parents are often as fragile as their babies, requiring patience, guidance, and encouragement to ensure that they are mentally, emotionally, and physically prepared to endure the pressure of a NICU stay. NICU Heroes is dedicated to helping NICU professionals like you better understand, support, and nurture the entire NICU family. Well, hey, y'all, welcome back to NICU Heroes. Our 2024 season is chock full of amazing experts who have such good wisdom to give y'all. I've really enjoyed my conversation last month with Dr. Penny in pediatric cardiology. This month, I'll be focusing on mental health with Dr. Stephanie Waggel. I know that mental health is something that we have certainly talked about in our parent podcast, but I felt like it might be a really good conversation to have here because as NICU professionals, you have a really unique relationship with your patient. Yes, your patients are cute babies, but you also have a relationship with their caregivers. And this mutual trust that you begin to create with those families, you see them probably more than most professionals in a hospital. And it's such a beautiful relationship and how you can get them to the places that both they and their baby need to receive assistance or help as they're navigating either a new diagnosis or something going on in their life. And so I felt like this particular topic might be one that you may be even more, I think, equipped to help them get connected to resources. And so I decided to speak to someone who had expertise that I did not, and I think you're going to love her. My guest today is Dr. Stephanie Waggel. She is a mother, physician, author, motivational speaker, teacher, cancer survivor, marathon runner, and founder of Improved Medical Culture. She has a degree in psychology, biology, and medicine, and has over 17 years of experience working in the mental health field. In 2023, Dr. Waggel became certified in perinatal mental health, specifically advanced studies in perinatal psychopharmacology. So that's medication for pregnant people. She feels this area is understudied and pregnant women deserve an educated professional to provide correct diagnosis and treatment. She started a free therapy group for this population, and she heavily advocates for expansion and integration of PMADS care. And PMADS is perinatal mood and anxiety disorders. You are going to love our conversation. So with that, let's chat. Well, I'm really honored and excited to have Dr. Waggel with me here today. Dr. Waggel, thanks for being here.
Oh, thank you for having me. I love talking about this stuff, so I get really excited.
I love that you're excited. So I think we should start at the beginning. How, of all the specialties, was psychiatry what you chose to go into? And I know recently you've really kind of shifted into perinatal. So I'm curious how you got there and why.
Well, that's a good question. So originally, way back when, I was always interested in, I guess what the average person would think is like strange, but like deep thinking, like the deep questions. I did a whole 40-page thesis on existentialism. And so it was kind of between like theoretical physics or psychiatry, because I was just thinking like either like really, really big cosmic or really, really small brain cells. And it's just the really the big questions about why and the existential questions were always something, even at a young age, I was interested in. And so I wasn't sure how many job opportunities there would be in theoretical physics. So I went to medical school. So in medical school, my love for the cosmic, like, why are we here, was also explored through my time working with some astronauts. So I did some aerospace medicine, and I like psychiatry, but I also liked going to space. Now I really wanted to be an astronaut, but I'm actually too short to be an astronaut. So
Okay. I don't
by
think I knew
like,
that there was a height requirement. That's good to know. Not
yes,
that it's on my
yes.
list, but
So I had to give that up. But so I worked in aerospace medicine, and there were 3 residencies in aerospace medicine, and I found myself at the meeting. So I'd go to these NASA meetings, and I met Neil Armstrong. It was really cool.
oh wow.
But
Wow.
one of the things, so I was always like obsessed with the solipsism, which is when you go to outer space and it's like, am I the only person that exists? And I realized that I was really into the psychiatry of it all, because there is a very rigorous psychological testing and monitoring that goes on with going to space. And I just like really love talking to people. And in most of the specialties, you don't get to talk to people for more than about 5 minutes. So I was interested in space and interested in psychiatry. And then I was also because I'm a big proponent for women, which you would think wouldn't need to be a thing, but apparently it's just, we're not very well studied. And I distinctly
Yes.
remember I was at one of these meetings with the astronauts, and they were trying to address this issue where, so ridiculous, or female astronauts would go to outer space and then become pregnant. And they were talking about giving them hysterectomies before they're going. And I'm just like, what on earth kind of
Wow.
suggestion is this? Well, it's not like they magically become pregnant on their own. And
Right.
so so there's a lot of psych to unpack with that conversation topic. And also, I just believe that women aren't well studied enough. Like, I'll get into it later, but it's as if pregnancy is this rare condition, because you always hear like, should you you should avoid cat litter, but should you not eat lunch meat, not do this, and not dye your hair, all these things. And it's like, no, nobody knows. And it's like, being pregnant isn't this rare phenomenon that
Right.
couldn't possibly ever be studied. And I don't think that female astronauts should undergo a hysterectomy before going to space. So I'm
Right.
like, okay, somebody needs to focus in on, what I call the therapeutic orphan. So on my YouTube, I have a list about, it explains therapeutic orphans, which are pregnant women, meaning that it's like there's really no realm, at least in any medical school I've ever heard of. There's never a class like how to prescribe medications to pregnant women. Of course, like in OB, like you can study like what are super like teratogenic, meaning will harm the fetus and stuff like that. But they just really don't go over, especially psychiatric medication for pregnant women. It's just not very well studied. So all these things were of great interest to me. And I still have like a hobby about, I'm still a space nerd, but I haven't gone to outer space yet. I'm not tall enough to go to outer space. But I became a psychiatrist because I'm really geeky in the brain and why people think the way they do and why things exist and like the cosmic reality. And if anybody ever wants to read my 40-page thesis on existentialism,
You're the gal to talk to.
yes. So I guess it's because I'm a super nerd. I don't know.
No,
So
I love that.
hopefully,
I love when people have passion for what they do because I think it gives us context whenever you share your wisdom and your practice experience or practical experience because I think that it gives us a lens in which to look through. So thanks for giving us a little bit of a lens into the earthly and the extra, a little out of the normal earthly realm as to what you're
that's
interested
right.
in. So there's a term that you know well, but maybe other people don't. So it's called PMADS. So can you give us an idea, like what does PMADS stand for, and what all does that encompass? Because I know it's more than just postpartum depression.
Well, I would love to. So
You're just the
I
gal,
actually, yes. And I use the word postpartum depression or the phrase postpartum depression it depends on who's listening to me talk. If it's the general population, I'll say postpartum depression. But if it's healthcare professionals, some of them actually might not know what PMADS is. The reason I use postpartum depression is because a lot of people are familiar with that. And so if I say that, I'm just using it in like general terms, but I really do mean PMADS. So the two main differences between postpartum depression and PMADS, besides the fact that very few people know what PMADS is, two main differences are PMADS encompasses a greater period of time. So postpartum depression is after you give birth, which technically that's not, but when you think of post, that's what the word post means. So postpartum, so after delivery. But PMADS is perinatal. So that's from conception to, and I'm not about rigid cutoffs, by the way, but in general, it's conception to about 1 or 2 years later. So that encompasses a greater time period. So that's item number one. Item number two is the range of symptoms. It encompasses a greater range. So in postpartum depression, that's depression. But in PMADS, which is perinatal mood and anxiety disorders, you have anxiety, you have PTSD, OCD. So I don't want to say like just depression because I'm not minimizing depression. Like depression is
right?
debilitating, right? But postpartum depression just encompasses depression, whereas PMADS, you can have the anxiety and OCD. So just to recap, because I love teaching, the two differences, one is PMADS greater time period and two greater range of symptoms. So now that we all know what PMADS is, I could throw it around more casually in conversation.
I love that. No, so you mentioned a lot of things, and some of those I experienced personally as a NICU mom. But I'm curious, what are some of the things that you believe like a patient may be more susceptible? Like, are there certain maybe factors in their life that might make them more susceptible to postpartum depression, perinatal mood? So any one of those things that you mentioned that might make them more likely to develop PMADS throughout their pregnancy or postpartum.
Because the mom ate lunch meat. No, I make that joke because I want to point
Right.
out, don't blame mom. My goodness gracious. There's just so many people that are like, oh, if you do this, you're going to have this. No, you know what the answer is genetic and environmental factors, most of which are completely not within mom's control. Okay. So it's not like she got PMADS because she had the lunch meat, right?
Right.
We need to
Right.
put those thoughts away. So there are certain things that could be in the realm of control, although in general, like if mom could do something about most of these, she probably would. And those would be things like environmental, like like not having housing. Usually, if you don't have housing, that's you're trying to get housing. That's not really your fault. Or like an abusive partner. Like some people may argue that that is, the fault of the people involved in the relationship, but they don't understand that sometimes when you're in these things, they're very hard to get out. So, unsupportive family, like abuse at home, socioeconomic disadvantages, like you have to go from house to house to house, or you aren't able to afford like the care. So these are sort of like obvious things, like negative environmental factors that most people would say, like, yeah, that's going to lead to bad things. Maybe 10% of them could be controlled, but the whole point is that I want people to know that if you have PMADS or you have these issues, it's not your fault. It's not anything you did.
Right.
And then if we get to the things that absolutely are not within our control, that's going to be like genetic predisposition, right? If these sorts of things run in the family, maybe in the future you could alter your genes, but for right
Right.
now, that's just kind of something that you're stuck with. So people that are more susceptible to PMADS, it could be obvious or it might not be obvious at all. It's really hard to tell. And you can't tell by looking at somebody what their genes are going to predispose them of. But if it's in that 10% realm of things that can be changed, if you can give them resources for maybe like support groups, like if you notice that the family is just not supportive of the mom and you're like, I noticed that maybe you could use some extra help. Here's some resources or here's some groups, stuff like that. So you definitely want to change what you can, but also not blame and assume that everything can be changed. Because like I said, you can't
Yeah.
change your DNA.
Well, thank you for saying that, because I think there's a lot of women and families that walk into the NICU feeling a lot of guilt for a lot of things. Like, could I have prevented this? Could this have been different? And so knowing that while there are some things, like you said, that are make you predisposed to maybe experience PMADS in a higher way, but the vast majority of people, it just happens because of circumstances. And it's not like if I had eaten a really good breakfast and I
Exactly.
had coffee this morning, my life would have changed differently. So I think it's important for people to hear that. So in your practice as a psychiatrist, Dr. Waggel, what's the most common thing that you treat with all of your PMADS patients?
Okay, so with PMADS in particular, which is the majority of what I focus in on. Sometimes other people sneak into the clinic, but I do try to really just hone in on PMADS in particular. It's typically, actually, you know what? I'd have to do a really in-depth because it's probably head-to-head depression and anxiety and a lot of both together. But surprisingly, and I don't want to go off on too much of a tangent, but OCD, and it's those unwanted intrusive thoughts. Now, my feed on my social media may be different than the listeners, probably because I'm always looking at like mental health stuff. But I've been seeing a lot of videos acknowledging the unwanted intrusive thoughts that moms are having. And then there's like a book, Good Moms Have Bad Thoughts. So,
Mhm.
as far as I know, it seems like it's becoming more talked about that moms have these unwanted intrusive thoughts. But maybe it's just because my feed knows that I'm interested in mental health. But the anxiety and depression, they're pretty common and typical, but I see a lot of OCD and unwanted thoughts, behaviors,
That
that sort
makes
of
me
thing.
think, I wonder, Dr. Waggel, how much of that is exacerbated or led because of our involvement with social media. Like you're seeing how other people live supposedly or how they're dealing with things, and if all of a sudden you start to doubt your own faculties, your own abilities and gifts. I'm curious. I don't know. That's maybe
Right.
another question for another day, but I don't know. Surely social media has to play into some of those things that people are feeling, certainly with anxiety and some of the other things, I would think.
Yeah. So, especially with young people, so it's sort of a generational thing too, is that for my generation, I was a teen. I guess there wasn't really social media. We had AOL and stuff. So like you didn't get that glimpse into other people's lives that you do today. Now, like it's like everybody knows way too much about everybody else.
Yes, we do. All right, so let's switch back to both PPD and PPA. So we're talking about postpartum depression, postpartum anxiety. Dr. Weigel, when a patient comes into you, how do you diagnose that they are experiencing one of those, or in some cases, like you said, both at the same time? Like, what are some things that you do to say, yes, this is why I believe that you are suffering from postpartum depression, postpartum anxiety, or even both?
So that's a very good question. And I guess I could rigidly follow the DSM because there's like diagnostic criteria. But that's not really what I do. What I do is I look at how much of a hindrance it is on their daily life, how much it bothers them, how much it interferes with their activities of daily living. So when you have a newborn, in general, you're probably a little anxious. And in 70% of women, they have the baby blues, which is, you're crying randomly and you're feeling sad. But that's not diagnosably like depression, right? The thing that I look at is how debilitating is it, right? Are you like unable to shower and take care of yourself and do the normal things that you would want to do? And so I basically look at how it interferes, and if it reaches a threshold that it's they're not being able to do things that they need to get done, then that would be to me an identifier that it reaches the threshold. But of course, there's like specific criteria that different disorders have to meet. But in general, I look at what I say is, especially for OCD, I have this like big red button, and if you could press the big red button and make the symptoms go away, would you? Because sometimes people have like symptoms, but they're not causing them problems and they actually like them about themselves. And so sometimes people are like, oh, you know what? This feature about me is a little odd or, atypical, but I don't mind it. So I wouldn't press the button. And then I'm like, okay, then we don't need to focus in on that. But if it's like, whoa, this is debilitating, I can't function, I'm pressing the button, I'm like, okay, well, then it reaches a threshold and we got to do something about it.
That is a really interesting analogy. I'm sitting here thinking about how that might have been effective whenever I was dealing with some of the things that I was dealing with, that button mentality of what can you live with and what's too much. That's really good. Hey, you should be a psychiatrist. You're really good at this, Dr. Waggel. So most of the people that listen to this podcast are NICU professionals. So they're looking for continuing education credits, and they're finding themselves interacting with, in their case, NICU moms and dads in a NICU setting. So what would be some things, Dr. Waggel, that if they observe those things that they might suggest to their patient, hey, maybe let's talk to the social worker, or let's see if we can get you some help outside of the hospital. What would be, and I know that what they see is just a little bit of a microcosm of their life, right? Like they're hearing about their life, but they're really only seeing them in the hospital. But what would be something that might be some red flags or some things that might be a little cause for concern?
Okay, so this is a good question. So before I get into the red flags, I want to say, in general, I think everyone should be screened. Even
Agree.
if there's no red flags, because a lot
Agree.
of the stuff, it's like you might not be able to see it. So the ACOG and then the American Academy of Pediatrics has their recommendations for how often moms should be screened for postpartum depression. And so for ACOG, it is at some point during the pregnancy, at least once they should receive a screen. And then actually, the American Academy of Pediatrics is like at the 2-month follow-up, 4-month follow-up, 6-month follow-up. And I can tell you very infrequently has it ever fallen into this pattern, but those are the recommendations. And so I'm going to say that in general, everybody should be screened. It could be awkward for people, but if you generalize it, like, this is just something that affects a lot of people, and we just want to make sure that you're well taken care of, and we want to provide you with any resources should you need them. We're not saying you necessarily need them, but we just want you to know that these things exist. So now I'll move on to red flags, because sometimes, and a lot of times, there are no red flags. Okay. So you just screen everyone. But like I was saying earlier, if there's like fighting or lack of support, or people are coming in and yelling at the mom, or you could kind of just tell if there's some tension in the air,
Right.
or it just feels like lack of friends, like if she's completely by herself and doesn't have a support person there in the room, that sort of thing. So you could say like, or maybe she just doesn't want to deal with other people getting up in her business, and that might not be a problem at all.
Right.
But obviously a huge red flag is if there's like fighting or screaming or any kind of, I mean, it should be very obvious, but like abuse or shaking the newborn, or like anger issues, or objects flying across the room. So those are some big red flags. people don't typically, well, sometimes maybe they do, but typically volunteer to their healthcare professionals that when they're in the delivery room that they're like having thoughts of suicide because they're worried that like they'll be branded as crazy or taken off to an institution or something. So infrequently do they volunteer, but that would be a pretty big, I don't want to say red flag because then I feel like red flag is negative and I don't want to discourage women from telling their healthcare providers that they're feeling this way. So I won't call it a red flag. I'll call it a sign that they need help. And so if they're straight up saying, you know, I'm having thoughts of harming myself or other people, that isn't a red flag, but it's a sign that they need help. But I feel like you're not going to get that out of them. That's going to be something that you're going to have to normalize and talk to them about. And so it's a little bit difficult in the, well, in the NICU, being in the NICU in itself is actually a red flag or just a warning that things could be aggravating. So,
yeah, no one's doing okay in the NICU. It's a hard place to be.
Exactly. So that in itself is something.
You know, actually, you said something, Dr. Waggel, that got me thinking. So not too long ago, I did an interview with Dr. Rankins. I know that's actually how I found you. And we were talking about this screening factor that a lot of times NICU moms fall through the cracks because they are not going to see their OB on that regular schedule because they're still in the NICU with their baby. Their baby's not going to the pediatrician yet because either they're still in the NICU or they're finding themselves at a specialist office. So they sort of fall through the cracks. Like there's not even she said it, she's like, you know what? I don't know if we have an actual screening that we do in the NICU with NICU moms. It's not really a normal thing that they do in the NICU. At least it hasn't taken off yet. There's a hospital in Austin that's doing it, but there's sort of an anomaly. And so they have this 3-prong approach of psychiatrist, therapist, and a social worker. So it's like everyone is sort of eyes on the people that are taking care of the babies that are struggling. So, but that doesn't seem to be a normal thing. It's like this big gap in care as to how the screening part. So I think we need more people talking about how we can address that because it's sort of this thing that falls through and no one really realizes it until they're too late. And then maybe they come see you months later and they're like, if only I had known, you know, months ago. So I'm glad that you mentioned
they could like put like a poster on the wall, like normalizing, like, oh, okay. So it's 1 out of 5 to 7 moms and 1 out of every 10 dads has postpartum depression. So maybe it would be like a poster, like, did you know that it's this common? And then people will be like, I didn't know it was that common, but now that I know, I'll talk about it. So posters are just, it can be very awkward, especially for people that didn't have much psych training to just be like, so are you having suicidal thoughts? In fact, in medical school, one of the concerns is that if you ask somebody if they're having suicidal thoughts, it'll give them the idea to have suicidal thoughts, but that's not really how it works. But it can be difficult for some healthcare providers to just strike up the conversation like randomly. So maybe if there was a segue, like maybe the poster, I'm telling you, like if it was just, oh, look at that poster that says how common this is. Did you know it was that common? Like something like that.
There's like a unique relationship too with a NICU nurse and a family because as opposed to just a nurse who flies in and out on the day shift or on the evening shift, these are nurses and in some cases become their primary nurse. So they're seeing them on a regular basis. So I know in our case, we got to know our nurses really well. And so when you start to have this trusted relationship and it's your NICU nurse who looks at you and says, Are you okay? You know, how are things going that you feel like you can open up? At least I did because we saw them so much and we knew that they were taking care of our baby. So it's a unique situation that might be that segue, you know, that they have this relationship with the family. There's a mutual trust there. And not only we knew that they were caring for our baby, but we also knew that they cared about us. So it's a hard, but a unique place, I think, to be in that people are always attuned to how can we help you? It's just a unique medical place to be. Man, we could talk about all that all day. All right. So I'm going to switch over to treatment options. So Dr. Waggel, when a person comes to you and says, hey, this is what I'm struggling with. This is how it's interrupting my daily life. Like, what would be some of the things that you would look at them and say, okay, and I know it's individual to each one, but what are some just general strategies that you would use to help them. All right, so I see where you are here, and now we want to get you to here, and these are some of the steps that we can take. What can someone expect to experience as they go through this interaction with you and overcoming or learning to live with their postpartum depression, postpartum anxiety, OCD, PTSD, all the things?
Well, the steps from the NICU professional and then the steps from me are obviously going to be different steps. So, as
Right.
we were talking about before with the NICU professional, the steps are going to be normalizing what's going on and kind of trying to screen without being too aggressive, or like, oh, are you going to harm the baby? Like
Right.
a very tactful investigation in protective factors or risk factors and that sort of thing. So the NICU professional is looking into normalizing and then referring. And so I'm not sure I would expect a non-psych professional to know the different levels that they should refer to. So I would just say in general, refer to some mental health provider and then they'll eventually get to the right place, because I don't want to put
Sure.
I've already assigned the NICU healthcare worker with like this anti-stigma and the screening. I don't want to assign them the triage with where they need to go. So I'm just going to say, if you could get them to a professional, somebody who has mental health training, then they will get to the right place. So once they get to the mental health professional, so if they get to me, there's 4 different levels of mental health care. And so the basic standard outpatient level is going to be a therapist, a psychiatrist, a psychologist, that sort of thing. And that's when you just check in like a regular doctor's appointment type of thing.
Yeah.
But if the mental health condition is more severe, so for example, if it requires like more close monitoring than just checking in every couple weeks, there is something called intensive outpatient, which is still outpatient, but as it described in the acronym IOP, the intensive it's intense. So it's a couple hours, maybe like 3 days a week. And so yeah, a little intense. But if you need more than just your regular run of the mill outpatient, like then that's where you would go. So that would be, and you might be asking, well, who? And that would be if people aren't able to like go to work or school. If you're postpartum, hopefully you don't have to go to work or school, but some people do, right?
Right. Yeah.
And so if it's really hindering your ability to get things done that you need to do. And then if there is, for example, substance use or requiring some like nursing, then that would be like a partial hospitalization, and that's 5 to 7 days a week, like all day. So like 8 hours a day, but you don't sleep over there.
Right.
And then if it's the highest level of care, which is inpatient psychiatric hospitalization, that's if there's a genuine risk for harm to self, harm to others, or there's like psychosis, which I could get into if you need me to later. Or like the patient is so disorganized and confused that they're like they can't tell you where they live, like that would be inpatient hospitalization. So just to recap, the healthcare worker who doesn't have much training in mental health, their responsibility would be normalizing and giving resources and then getting them to a mental health professional. And then, well, if they figure out which kind, that's great too. But I think,
Sure.
Let's not overwhelm them. And then
Right.
once the patient gets to the mental health provider, that mental health provider can decide which level they need. Does that make sense?
No, that's incredibly helpful, because we can't expect every person that interacts with you and your baby to be an expert in everything, cardiology, mental health, all those things. So,
Yes.
but then they would be superhuman, which would be amazing. They already are a little bit superhero in my mind, but this ability to say, okay, we know what our role is, and
Yes.
how far can I get you? It's kind of like the marathon, and I'm going to give the relay, and I'm going to give the baton to the next person. So I know like where I can get you to the first pass off, and then the next person
Mhm.
has to take you from there. But I think knowing who to send them to or knowing what resources are available can be really helpful for a family as they're trying to figure out what to do because it's overwhelming. But our NICU nurses and NICU professionals certainly know, okay, these are some of the resources available and this is how we get you there. So no, incredibly helpful. This podcast is produced by Hand to Hold, a national nonprofit, but we're more than simply a podcast. Hand to Hold is here to support your NICU in two ways. One, you can refer your NICU parents to us for support, or two, you can bring dedicated Hand to Hold support to your NICU, either in person or virtually. Our support consists of one-to-one group and educational resources, including our family-focused podcast, NICU Babies Parent Support. For more information, visit handtohold.org and click on NICU Professionals. I'm curious, as someone who works in the mental health care field, what are some things that people can say or do that are very helpful to someone who's struggling from PMADS? And then what are some things that they can do or say that are not helpful?
Okay, so I'll answer this in two ways. I'll answer this as a non-medical professional, things that are helpful and not helpful, and then I'll answer it as things that are not helpful that medical professionals can do and do unfortunately do, and then things that medical professionals do that are genuinely helpful. So we'll take your average run-of-the-mill muggle, I guess
I love it.
non-medical
I
person,
love it.
Harry Potter reference. So a non-medical person, what is not helpful is like giving this like unsolicited advice. And I didn't realize how ridiculous this was until I became a mom myself. It's just like, if you don't know it to be true, then stop advising people of it. And so I think, if you're not a medical person and somebody's struggling, don't minimize and just be like, oh, you'll get over it. Or, oh, I can't believe that you're worried about this or that sort of like, no, don't do that. But as a non medical person who is doing something positive for the individual, if they would say, you know what, you deserve the best treatment you can get for this. And so I think that you should see somebody like professionally that can provide you what you deserve. Because if you word it like, oh, you need to get mental health help, then I think that could become offensive. So I think the key word is deserve. So if you say,
I love that.
you deserve the best help you could get, that is much better worded than like, you need to see somebody, right? Because that could be offensive. So the general person that's not in the medical field, it's not helpful if they minimize or just dismiss people's concerns. And it is helpful if they use the word deserve, like you deserve the best treatment you
I
can
love
get
that.
for this, and not saying like you should see somebody. And then when it comes from a professional, the thing that I see a lot, unfortunately, and this is getting back to this whole therapeutic orphans issue that I was talking about earlier, is that they get real scared when someone's pregnant and they don't want to take on the
Right.
liability. So they just say, like, don't do anything. Um, and so the example I give is a pharmacist. So first of all, the pharmacist shouldn't just assume somebody's pregnant, because you're not supposed to just be like, are you pregnant? But so the pharmacist sees a very obviously pregnant individual and they're going to get their steroid for their asthma. And the pharmacist is like, oh, you don't know what this will do to the baby. I'm not giving it to you. So that is a not helpful thing that a medical professional is doing, because to them, not doing something removes the legal or moral liability. Like, oh, well, I didn't cause the issue because I didn't dispense this medication. But they don't really realize that the act of not providing the help in itself is a hindrance. And so the pregnant woman goes home and she has an asthma attack and then she can't breathe. But at least the pharmacist can sleep knowing, it's not because of anything that he gave to her. So that's an example of a health professional not doing something helpful for somebody with, well, in that case, it was asthma, but the same could be applied to like a mental health treatment. Cause I see it all the time. Um, Prescribers are like, oh, you have to stop your medication, you're pregnant. Well, that could be more detrimental than continuing it, and in most cases it in fact is. But a good thing that a either mental health professional or just healthcare worker in general can do is recognize their limitations. And so the pharmacist might say, okay, I am terrified to dispense medications to somebody who's pregnant. I am going to refer them to this other pharmacy where I know the pharmacist is comfortable with it. And the same could be said for a prescriber that's like, I'm now horrified because you're pregnant. I don't know if I should continue your medication. They need to realize that this is not their wheelhouse and that they can refer to somebody that is more comfortable. So that answers, I suppose, the good and the bad from non-health professionals and the good and the bad from health professionals.
Well, I'm glad that you brought up, thank you for that. I think that was really helpful on both sides. You brought up medication but yet pregnancy's been happening since the beginning. So this is not like you said, it's not a new condition. We're not like, oh my gosh, people are pregnant. I've never heard of that before. But yet,
exactly.
But then we have this medication piece, like you said, that, I mean, any number of conditions, whether they are mental health or other conditions, sometimes require medication. And it's a medication that in many cases maybe should continue through pregnancy. How or who, if you're experiencing some sort of medical condition, you have this medication, and then someone says to you, oh, you should stop that medication. Who's the best person to answer the question of, yes, you should continue that medication, or no, you shouldn't? I know some of it's a life and death kind of thing, and some of it, we worry, is it going to harm the fetus? But give us an idea of, if you're pregnant and you're on a medication, who can best answer the question of, yes, you should continue that, or no, you shouldn't? Because I think it's a hard thing. And like you said, not many pregnant people go participate in studies even so that we can figure out, does it help? Does it not help? So I'm curious what you would recommend.
Okay. So there's two things that I want to address. Make sure I get back to the second one, which is regarding pregnant people in studies, because I have some things to say about, obviously, like why that could be unethical, pregnant people in studies. But okay, so the best person to give this advice, to my knowledge, there are 3 physicians. I'm from Virginia. There are 3 physicians in the state of Virginia who are perinatal psychopharmacology certified. So myself and 2 others. So there's like slim pickings.
Wow.
The way that I would say to find the right person is to go to Postpartum Support International, and then there's like subcategories, like there's Postpartum Support Virginia. So whatever state you're in, there's going to be a database, and that will show you providers who have had either some training or a certification in this specific field. What you don't want to do is assume that every doctor has this training, because like I said, it's just really not well discussed in medical school. And so I think the unfortunate thing is that women will go to their primary care assuming that they know how to prescribe to pregnant women. And then if they say something or contradict another prescriber, then that leads to the pregnant person having a distrust for medical professionals. And I can't blame them, because if different medical professionals are giving you conflicting advice, then I would also distrust them. So don't assume that every medical professional is going to know how to prescribe to a pregnant woman. And do go to Postpartum Support International, and then, whatever region you're in, it will have a list of individuals who have had training. And then I wanted to get to, so as it boggles my mind that there's still, like, every single label is like, consult a doctor if you're pregnant, and then you consult your doctor and the doctor's like, I don't know. It's like, why don't
it's on
we know?
every medication.
Yeah, but that's because no one wants to take the liability and say, yeah, this is safe. And then something happens. They're like, you said it was safe. So nobody wants to take that responsibility. But there are things that are pretty safe. And I don't want to digress into that. But I do want to get in specifically to when you're doing a study, if you have a pregnant person, you're not going to get the IRB approval to do the study very easily because they're a sensitive population. And if you know that a certain thing works, you can't really like withhold that. It's just not ethical. So the ethical concerns that exist with doing experiments on pregnant people are vast. And I do believe that that's why there's just such limited data. So, what is the solution to this? Well, I have a solution, in fact, but it requires. I know why the solution isn't as popular. So, the solution would involve, like, let's say I have 10 patients and they absolutely need an antipsychotic and they're pregnant, and we'll just call the antipsychotic Sam. I don't know. So Sam is the name. I didn't want to say a specific
That's okay. No, that's
antipsychotic
smart.
because I don't know, because this is just this is a hypothetical. And so Sam, the antipsychotic, all 10 of them are taking it, and there's no data because you can't like have them take it and then go, be in the study. But what they can do is volunteer. So if I could give like links later on. So Massachusetts General Hospital has if you are taking this antipsychotic SAM, you can sign up on the website, and then periodically they'll ask you questions like, are you having this issue? Are you having that issue? And that is an ethical way to obtain data about a medication without experimenting with the mom.
Right.
But the problem is if you are pregnant and you're having mental health difficulties, are you going to have the time and energy to fill out these surveys? And so that's why I don't want to make the moms feel guilty, like, oh, the reason we don't have data is because you guys aren't signing up for these studies because you're so busy being pregnant and then having mental health issues. So it's just really difficult to obtain the data. But like, let's just say you have a little extra energy and you want to contribute to science, and you're pregnant, you're taking a certain medication, you can sign up and report your progress or your side effects. And then eventually, if enough people do this, then we will have data and we will be able to answer some of the questions like, can I take this while pregnant?
Thank you. No, I think that's helpful. I'm glad. Yeah, I mean, I think you're right. I mean, everyone that's going through a mental health crisis, the acuity of that may be very different. And so some people may have the bandwidth to participate in that and some may not. But having that data can only help future pregnancies and future moms. And as we start to figure out what medications, did we used to think were not okay and now they are. But you're right. Every single bottle of medicine that I take, I still look, and the pregnancy warning is on every single one. So it's definitely, I think it leads, I'll say, I mean, to me, it was like, I can't take anything. And my husband was like, I think you can probably take a few things, but you start to freak out. Like,
true.
I can't eat meat. I can't take Tylenol. Like I can't. So all the things that you can't do, and it starts to feel overwhelming. So this is kind of, I think, a big breakthrough. And at the end of 2023, I'll see if I say this drug name right. Zuranolone, hopefully I said that right, was approved by the. Oh, I did. Okay, good. Was approved by the FDA to help treat postpartum depression. So I know that's kind of a first drug to be able to do that.
Isn't that crazy that 2023
I know,
is the first drug? We only had to wait thousands of years.
Man, I had 6 babies and it wasn't around, so you never know. But I'm curious what you're seeing in your practice, like how effective. I know you may not have a lot of data just yet, but what makes it so promising? And are you seeing some things in your practice that give you some hope into how it can treat a pretty common condition among moms and those who are giving birth?
All right. So very good question. I could talk about Zuranolone for hours. And in fact, I have on my YouTube, if you want to hear me talk
We'll
about
link to it. We'll link to
for
it.
hours. Okay. So it is very promising. So let's see where I want to start. The most promising thing in my mind is that means that it's on somebody's radar and that pharmaceutical companies are starting to care about pregnant women. So I think more than the medication itself, the fact that now at least something is finally FDA approved for postpartum depression, that's a good sign.
Yeah.
Okay, so that's great. Now, if we could just get to the actual medication. So I don't want to say, I'm very skeptical of everything, but there are a lot of really good positives with this. But then there was a recent JAMA article that came out in December that I also want to address. So I'll take it. We'll talk about my initial research and then my comment on the recent article. So my initial research, very promising, although I take it with a grain of salt because the research was done by the company that's selling it. And it's like, oh, well, that's maybe a conflict of interest. But one of the big things that I always get asked is, how long do I have to take this medication for? And so with Zuranolone, the answer is 2 weeks. Unheard of. Wild. I have like a psychiatric medication that you only take for 2 weeks. And so that's super promising. Another promising aspect of it is that it starts working in 3 days, where most antidepressants, they start working in 6 to 8 weeks. So it's like, oh, okay, I guess I'll be waiting. So you don't have to take it for long and it starts working. And then the studies also showed that it's still effective years later. And so these are all very good signs. I cannot tell you how effective it is because it only recently came out. And the one time I tried to prescribe it, it was not to be found in the pharmaceutical database. And it's still estimated to cost, everybody brace yourself, between $10,000 and $30,000. And so I don't have anybody that's going to sell their car and take it. So I cannot tell you firsthand that I have prescribed it because it's not very feasible to get. So this is the first pill that is FDA approved for postpartum depression. There was an IV, and still is, to the incredibly wealthy, Zuranolone IV infusion that occurs over 60 hours. You have to be in the hospital, and that also costs about $30,000. So it's nice that it now exists in a pill form, but the price is kind of a little limiting to people.
Yeah, I mean, there's no way. I mean, we were trying to keep our baby alive, much less a $30,000 pill is never going to fly at our house. So do you think that's going to go down? Like, do you think it's going to be more accessible to like regular people instead of people who live in the Hamptons? Like, I'm curious.
I wish I could understand it. Well, maybe GoodRx will have a coupon for it. I don't know.
Oh, that's right.
I cannot tell you. I can't tell you how they pick these prices, or I don't know who are they going to sell this to. But maybe it will go down. So it works similarly to a benzodiazepine, although it has an additional mechanism of action that benzodiazepines don't have. And for that reason, my concern with it is like misuse. But if it does truly treat postpartum depression, that's more important to me than being worried that the patients are going to abuse it. Obviously, they're abusing it. That's not good. But they only get a 2-week supply. So and anyway, you're not going to abuse something that costs $30,000.
Right. Yeah. Who's got that much money to throw around? If you do, then we need to be friends. But yeah.
Yeah, exactly. All the research that I looked at is just like, besides the price, it's fantastic. It's, quick, and you don't have to take it, and it works for a long time. But then there was a JAMA article, and I don't know wherever this is going to be posted. If somebody knows why this is the case, I'd be delighted to hear it. The JAMA article is a bit critical of Zuranolone. And the reason being is that it says that the studies are comparing Zuranolone to substandard care, whereas the studies should be comparing the medication that it's investigating to the standard of care. And so the JAMA article takes issue with that. But the JAMA article looks at only 2 studies, the Robin and the Skylark study, but it doesn't talk about the Coral study. The Coral study does compare Zuranolone to the standard of care. And so I'm getting a bit nitpicky, but if somebody has read this, or I don't know, hey, maybe the authors of the paper are listening, if they can explain they're critiquing this drug for not having a study that compares it to the standard of care, but they neglected to talk about the actual coral study where Zuranolone is compared to the standard of care. So I don't really know what's going on with that. So they're kind of two thumbs downing the Zuranolone, but then they're also not addressing an entire study. So it's hard to tell what is going on, especially if I can't even prescribe this medication. I can't tell you if it works, but if a billionaire comes to me, then maybe I'll have better information for you.
Yeah, he's like, so I've got a couple $1 million laying around, and I hear you have patients who need medications. So let's do this thing. So the hope is, I mean, I always feel like when medications first come out that they are incredibly expensive, but then over time they start to come down. Yeah. Yeah, if the makers of this drug are listening, come on, if you have this amazing drug, let's make it accessible to people that it can help. I mean, that's why we do these things is to alleviate, symptoms, but also give people a quality of life that they're desiring and that they deserve. I love that you said that earlier, that they deserve to have. I'm always curious, Dr. Waggel, when you treat mental health, and I'm thinking back, 14 years ago when we had our NICU baby, the fact that we went to marriage counseling was so taboo. Like, we had so many people like, I can't believe that you're telling people out loud that you're in marriage counseling. So I'm curious to know what maybe might be some myths that people may have about mental health, or even people who treat mental health, that are just inaccurate or maybe outdated information. Because I know in the last decade or so, certainly more people are talking about it, and the stigma is becoming less and less. In fact, it's becoming normal to say, hey, yes, I have a therapist, or yes, I struggle with depression or anxiety. That's becoming more normal than it was 14 years ago. But what are some barriers, or what are some myths that you think people have about mental health that you'd like to say that's super outdated? This is where we are now.
Oh, there's so many. We could have a whole other podcast. So specifically when it comes to marriage counseling, there's a myth that you need to be having a problem to go.
Mm-hmm.
You could have I don't think there is a marriage that has no problems, but you could have your, let's just say, standard run of the mill amount of problems in your marriage. Marriage counseling can help, like, if you're not, let's not say you're like fighting or anything, but it helps with communication, or it can help with like time management around the house, or even like chore allocation. So let's say you and your partner, you're not necessarily fighting, but somebody's definitely doing like the bulk of the household chores, and it can help with all sorts of things. So it doesn't mean that you're on the verge of divorce, or that you're necessarily having problems. It could just be like just get as much as you can out of your marriage. So that's one myth, is that you need to even be having problems in the first place. And then, this is a big thing that kind of drives me nuts, is the ABCX categorization of medications. So whoever's listening, I'm sure at some point that you've heard like, oh, that's category X or something like that, which just reiterates my belief that I went to medical school, but I'm sure it's similar in all the different training, that they're not up to date with the prescribing guidelines for pregnant people, because there are people that I do believe to be well-educated, respected physicians that are still using these ABCD alphabet categories when they were in fact abolished almost 10 years ago, but people are still using them. I don't know why. Well, I do know why. It's because they're not teaching this stuff. So that it's not a myth. It's gone. Like, if anybody, now it's clinical considerations. They should have come up with like a cute, catchy thing, kind of like the alphabet, but I don't know. So the clinical considerations are now the guidelines, similar to what ABC X and all that used to be. So if your prescriber says, oh, you can't take this, it's category C or whatever, that could be a hint that not necessarily stop seeing them, but maybe get a second opinion.
Right. Well, I think that there are so many things that have happened in the mental health field in the last decade, and certainly before that, but I've seen a rapid, and maybe it's just because I'm more aware that, we decided to go to marriage counseling, but I'm really grateful that you mentioned that. I think sometimes people think that they have to be mission critical, like their world has to be completely falling apart in order for them to ask for help. And I think what I'm hearing you say, and I hope what people listening to this hear you say, is that it's okay to go talk to someone, even if what you feel feels minor or small, that you could be setting yourself up for great success as you get older, as your NICU baby maybe enters a new phase of their life, or your marriage or your partnership enters a new phase, that you have this ability to live life more fully and with a lot more joy, by addressing some of the things that maybe if you had waited longer, they would have gotten even bigger and could have been even harder to overcome. So I'm glad that you mentioned that. I think we think that it has to be burning down in order for us to ask for help, and that doesn't always have to be the case.
Correct. Prophylactic, taking care of it ahead of time.
Well, we do so many other preventative exams. I don't know why we don't see mental health in the same regard, but that's another, like you said, that's another podcast for another day. That's so good. Well, I always ask this at the end because I love to hear a little bit of your vision combined with your wisdom and your practical experience. So, Dr. Waggel, what's your hope for the next decade in mental health? Like, what do you hope that we can accomplish or see here in the next decade as people start to become more aware of mental health and we start to treat them better?
Ah, fabulous. Okay, so this is where maybe I can implement some like magic powers, my wish making skills. So I definitely, the audience has probably picked up on this, is that I definitely feel that pregnant people are not given the full chance. They're just dismissed because it's easier for the healthcare field to just not actually engage in providing them with something. It's more of the lack of care. So in the future, I hope that there are more programs that incorporate education about how to treat pregnant people. And that way I don't get these frantic texts from my colleagues like, hey, I have this patient and now she's pregnant and I don't know what to do. And I'm like, oh my goodness. So in the future, hopefully I get less frantic messages like that. And since we were talking about it, I think in the future, if it was more mainstream to be preventative when it comes to mental health, and you're right, it shouldn't just be waiting until your whole world implodes to get help. And like I said earlier, like you might not necessarily even have like that, like big issues, but talking to somebody can help with all sorts of things. And so waiting until the world explodes, you're waiting too long. So maybe in the future, it'll just be like commonplace just to take care of things as they happen instead of letting things like build up until they explode.
Yeah. Well, this roller coaster of emotion, instead we become a little bit more steady, and as hard things happen, we know what to do. And this ability to have access to care when it should exist, because we should all have joy and we should all be able to experience hard things, but also to be able to move through those. So, Dr. Waggel, thank you for your expertise in really treating, and I think honing in on women, and also this really sensitive and beautiful part of babies and how that affects our lives, but also how it doesn't have to affect them negatively, and that there are people out there who really have this existential desire to help people. I love that you combine your
cosmic.
I do. I love that you combine this love of the human mind with helping people through hard and difficult things and coming out on the other side of that. It's a beautiful career. So thanks for sharing your knowledge with all the people that are listening. But personally, thank you for sharing them with me. Thanks, y'all, so much for listening. That was a fantastic conversation. I hope that you'll do me a favor. If you love today's episode, please share it with a friend. You can also review over on Apple Podcast or Spotify or wherever it is that you listen to podcasts. You can also give us a listen and a watch over on YouTube. It's how we reach more NICU professionals. Today's podcast episode is sponsored by Reckitt Mead Johnson, whose mission is to nourish the world's children for the best start in life. For more than a century, they have led the way in developing safe, high-quality, innovative nutrition products and continue to push the boundaries of nutritional knowledge with consistent, strong investments in scientific exploration.